Hello. It's always a bit weird when you say hello and nobody actually says it back to you. But we'll roll with it. Thank you for joining. Thank you for joining. It is actually fun enough if you've never been to the United Kingdom. Actually, it's a beautiful sunny day. I've had to block it out, otherwise you won't be able to see me. Now, I'll give you a brief introduction into who I am. If you haven't met me before or you were not on the course when I came, my name is Jimmy Michael. I'm one half of OMT training. Now, my background is from sports and exercise science into sports and remedial massage therapy, then into osteopathy, which in the United Kingdom, the UK, is a 4 or 5 year degree. Now, what we're planning to do today is discuss certain aspects of manipulation into why we do it, what's the point, how we use it, what setting, and you guys will be able to at some point ask me directly some questions, and hopefully we can get those answered for you. Now, also on top of sort of background of education, I've co-authored 3 or 4 books now. One you can see behind me, which is in osteopathic mobilizations, what we call articulation. And if you're looking at it, if you look carefully, you'll see that it's been translated into Korean. Awesome. But what we're discussing actually is what I've got just here, bear with me, is spinal manipulation. And you can see it's got osteopathic and chiropractic techniques on there. And what's just been released, so this was volume 1, and what's just been released is this, volume 2. Now, the difference between the two, well, volume 1, volume 2, basically the difference between this and this is this one just adds more techniques. So should you really get both of them together? Well, yes, you should, because actually you'll be covering everything. And if you stay on long enough, the doctor will kindly talk you through something regarding the books. But everything we do is based upon these. So everything that we discuss is within them at much greater depth. When you come on the course, the pictures that we give you in the course handbook, that is all based on the book, and we use the pictures from within the book. So we don't give you a cheaper picture as such. We give you the pictures that we use in the book directly in the training manuals, and that's all available when you come onto an OMT training seminar in Dubai through Learnovate. So absolutely would love to have you and take you through it. Now, I can see somebody's not getting some audio, so hopefully that can be sorted. Obviously check your microphones and make sure that you are using your speakers and etc, etc. Hey, look, I'm not an IT guy. Now, let's kind of go through some of the main questions that people ask, and then I'll throw it out to you to see what questions you think I've missed. So the kind of question 1, what is spinal manipulation, or just manipulation in general? Well, do you know what? It's a very good question, because essentially your patients will ask you what it is, in the sense of you can't just walk up to a patient and say, can I crack your neck? Can I crack your back? And things like this. So manipulation for me is using a technique where we engage the barrier, so we engage the dysfunctional range of motion, and we use a short, sharp movement, and we apply an impulse to that area, which may or may not result in a click. Now, we'll come back later and discuss whether you need the click or you don't need the click. We'll come back to that. Now, the essence of understanding what it is you're doing is when a patient says to you, oh, yeah, my problem is X, Y, or Z, and you say, can I crack your back? And they ask you why, and you go, well, I haven't really got a good enough answer, but hey, look, it sounds cool, and I think it might get you better. That is not enough, but you need to keep it fairly simple. And the most simple way of them, this is after testing, and we'll come back to this also, but after testing, this is what I found your problem is, and I would like to use manipulation as a method to increase your quality and quantity of movement. That is essential. Quality and quantity of movement is what you're aiming to do. Now, fundamentally, is that different to any other technique that you use? What do you think? What's the aim of all your other techniques? Can anyone type fast enough? What is the aim of all your manual therapy techniques? Come on, somebody type nice and quick. No? What? It's to improve quality and quantity of movement, guys. That's essentially what it's for. So is manipulation the only technique you can use? No. Is it the best one? No. You need to understand that you can use any technique at any point in time that you think is best for the patient, not what you think is easiest for you. It's more what you think will get them better, the fastest. Now, what do we mean by better? What do we mean by better? We mean improving quality and quantity of movement. I know I can see some of you have put pain relief pain. Yes, look, that's essential, but that comes under quality. Improve movement, that comes under quantity. But what happens if you're saying these to the patients and you don't achieve these through your technique? What happens? This is why when patients ask me what I'm going to do in the treatment, my answer to everything is improving quality and quantity of movement. And I also reiterate to them that you may not get quality and quantity together. So sometimes pain does go down, but they still move with an antalgic gait. Sometimes they move perfectly, but they're still in pain. Can you see why we say quality and quantity of movement? Okay. All right. Now, another question I get asked is where, as you can see on the book, on both books, it says osteopathic and chiropractic techniques. So fundamentally, and you'll ask this by patients as well, it's not just fellow professionals, patients will ask you as well, what is the difference between osteopath, chiropractor, or osteopathic and chiropractic? Actually, I turn this around and I would say there are more similarities than there are differences. And I would say that is now applicable to all manual therapies. So you can call yourself a physiotherapist, an osteopath, spine whisperer, osteomyologist. You can call yourself whatever it is you think you want to call yourself. Fundamentally, we are all there for the benefit of the patient. We are all there to improve quality and quantity of movement. Okay. So in terms of overall differences, there's more similarities than there are differences. Fundamentally, there is a teaching difference between osteopaths, chiropractors, and physios as kind of the more mainstream. But actually, we all use almost identical techniques. We may just explain them slightly differently. So you can make your own mind up, but that's the explanation that I give my patients, that there are more similarities than there are differences. That's it. Okay, so we can move on to what we think that the effects of spinal manipulation. So what does it do? Can anyone type fast enough? What do you think it does? What do you think it does? Anyone type fast enough? See, this is when we got the touch typers going like this, like crazy. So I'll give you a couple of seconds just to join in with me, and you tell me what you think spinal manipulation does. Anyone? Okay, so the classic form over the years, you're talking about. I'm more talking about. Some of you are putting movements, improved range of motion. That's the effects. I'm talking what's actually going on within the body. So the most classic aspect of what people said was going on with the manipulations is that they were changing the position of joints, and that way they were eliciting the manipulation. Look, we've moved away from a biomechanical model. In terms of, we like to be evidence-based practitioners, and from the evidence is showing us. See, look, someone's just put improved spinal alignment. The answer is no. The biomechanical theory of manipulation is, at this point in time, I'm not saying it's impossible. I'm saying at this point in time, based on the research, it's fairly implausible in terms of actually having two joints that are misaligned and then you are aligning them. Okay, that doesn't really, that is not really supported in the research. I can see someone's put corrective of deformity. No, you're improving quality and quantity of movement. You are not changing the structural anatomical position of these joints. Okay, full stop, based on the current research. Further from the research, the changes from manipulation are neurophysiological in nature. And this actually stands for all your manual therapy techniques. So whether you use myofascial release, massage therapy, even if you use the guns, that people are using, chiropractors use activators. Anything that you are doing has a neurophysiological effect, and the biomechanical corrective aspect currently is not supported. But remember, I said earlier, I'm not saying it's impossible. And through further research, they may change that process. But at the moment, we have moved to a neurophysiological, where you are affecting the ascending and descending inhibitory pathways. You are affecting the body through the periaqueductal grey matter within the spinal cord, through the ascending pathways, and then into the hypothalamus, releasing your natural opioids, so your pain relieving chemicals within your body. That happens with manipulation, and that is fairly supported in the research. So we need you guys, and this is how we teach. We don't tell you you are correcting alignment, because you are not. If you are correcting alignment, you would see people coming in, and I can't really do this on a webinar, but they come in like this, and you click them, and then they suddenly do this. I've seen in spinal leg length discrepancy. That is unsupported. The changes in leg length discrepancy, that is changed. That is not supported, rather. Sorry, pardon. That is not supported in the research. What this is being, and this is stuff that has been spoken about for years and years, and it was stuff that was taught to me when I was a student, and it still didn't seem that plausible. Now, if you are discussing this with podiatrists, for example, or depends where you are, chiropodists, podiatrists, very similar professions, they would not even begin to try and make changes with anything less than a 3 centimeter difference of leg length. So we're coming along as manual therapists. As I said, manual therapists can mean anything, and saying, oh, you have a couple of degrees of change here, and your leg length is 0.5 centimeter out there. Well, actually, it's not well supported. You have one foot that may be a half size bigger or smaller than the other one, but we don't suddenly see people stretching each other's feet to try and make them aligned. So we've got to be sensible, and again, we want to be evidence-based and evidence-based practitioners, and currently it doesn't support it. We are dealing with neurophysiological effects, okay, and we go into much more depth in that scenario of what is happening through the afferent and efferent pathways, all within these 2 books. So I suggest you get them. Okay, so we've kind of covered why you use it, and you'll hear me saying over and over again, you're improving quality and quantity of movement, and you are not, and I stress you are not, correcting deformities. Okay, now when it comes to correcting function, Guys, you're the physios. What's the magic word within physiotherapy? What do you guys do more than any other profession? What do you give to your patients? Uh, the pelvic tilt is evident in scans. You may need to elaborate on what you mean by proper manipulation. So we'll come back to that. Emre, my man, well done. Well typed first. Exercise. Fundamentally. Full stop. Exercise. Movement is medicine. Okay. Now, when it comes to these misalignments and structural misalignments, okay, can you tell me the name of the book? Osteopathic and Chiropractic Techniques for Manual Therapists. Okay. When it comes to correcting things, it is exercise. Jose, yes, my man. I'm saying my man. I'm just assuming. Manual techniques followed by exercises. Yes. We have this saying in our clinics and in our teaching. 75% of your therapy should be done off the table, not on it. Does that sound? If I just said something that's profound, because it's not. It's not profound. Exercise is a fundamental key to function, and as osteopaths would say, structure governs function. If the structure does not have a good quality and quantity of movement, then the function will be decreased. Simple. Okay. That's why when my patients come in, I'm actually discussing with them and qualifying them to tell them that they have to have an active participation within their therapy. So what I'm not going to do is basically kind of just go like this and give them a sheet of exercise. They will get a lot of hands-on manual therapy, but they will also get a lot of exercises that are relevant to improving the quality and quantity of movement and also their structure to improve their function. Okay, that is what is absolutely fundamentally key. And that's what I want you guys to be doing. You're doing it already. You know the exercise stuff. You just need to make sure that you are giving them the manual therapy intervention as and when it's needed. But flip that round. Am I saying you have to rub and crack everything before you give exercises? No, that's not what I'm saying. If manual therapy is not warranted at a particular patient, so for example, you've decided that patient has come in with a shoulder pathology and you don't think manual therapy is the appropriate intervention, then go straight to the exercise. But I don't see what I've just said as profound. I think that's common sense. I think what's being lost is the ability to mold the two together. What I hear a lot of is therapists saying, I do my exercise therapy and my manual therapy. Why have they been separated? That's my question. And within our teaching, we are constantly mixing the two together to say that you should be looking at this from a manual therapy point of view and also an exercise point of view. And if your weakness is manual therapy, fine. There's lots of courses you can learn. When I mean manual therapy, manipulation, soft tissue work, myofascial release, whatever you want to call it, any other techniques you can think of. But then exercise therapy covers a whole range. It's not just resistance. It's not just throwing weights around. It could be TheraBand work, flexibility improvements. I'm more of I like to get my patients moving their body as a whole because that's really what it's designed to do. But if they have, movements that are not in line with what they should be doing, then I may break that down into smaller planes of movement to improve that, to then move on to multi-joint movements. I'm a bigger fan of multi-joint movements than narrowing down individual movements, but sometimes that's warranted. And as a therapist, like any other profession all over the world, you've got to be flexible. And being flexible, not from a bend your hand around your head. I mean flexible to step off from your patient and say, what is it they need? Do I need to crack them? Do I need to give them exercises? Can I get them doing compound exercises? Do I just need to do 1 or 2 manipulations? The more flexible you are in your techniques and your thought process, the better the outcome to the patient. Because fundamentally, patients vote for therapists with their feet. What I mean by that is, if you're a good therapist, people will stay with you. If you're a bad therapist, people will stay with you for a short term, but you're not going to get results and they leave. Okay. Okay. Let's talk about the click. So fundamentally, do you need the click? Answer me, guys, as I take a sip of my tea and look. It may look a bit background to you. J for Jimmy. What is the click? Can anybody type fast enough? And the second question that comes from that, Emre, what did I say no to? Do you need the click? Is that what you're talking about, my friend? Is that what you're talking about? If you're answering the question as no, do you need the click? I would agree, fundamentally, but also I'm actually going to disagree. You do need the click. We'll come back to that. But why am I saying no? Look, I've written 2 books on clicking people, and I'm telling you, you don't need the click. What I'm not saying to you, because people sometimes misunderstand when I say that. What I'm not saying to you is don't do the technique. What I am saying to you is, if you do the technique and you don't get the click, it doesn't mean it hasn't worked. So let's just talk about what the click actually is. Now, what the click is a change in the pressure gradient within the joint. Now, then what that does by changing the pressure gradient in the joint, it moves synovial fluid around much faster, lubricating the joint. And by lubricating the joint, you desensitize the nociceptive pathways surrounding that synovial joint. Perfect. So on one hand, I'm saying to you, you do need the click. On the other hand, I'm saying you don't need the click. Actually, putting the patient into the position for the manipulation may actually be enough to change the pressure gradient in the joint, thus improving synovial fluid movement, decreasing nociceptive pain, and ideally, what did I say earlier? Improving their quality and quantity of movement. So if you do a manipulation, for example, and you actually complete it, so you do the short, sharp movement, but you don't hear the click, what do? I tell you what you don't do. You don't smash up the patient, another 15 goes until you get the click. I've seen that before. How many of you have seen that? I've seen that loads of times. I've seen that from lecturers that taught me many moons ago. And I used to sit there as a student going, oh, it was almost like one of those car crashes that, you kind of, I don't know, to be honest, I've been home for a while due to lockdown. So I've been watching a lot of those kind of, America's Funniest Videos, and you see people doing weird stuff and you kind of go, oh, I don't want to look, but secretly you look. That's what you shouldn't be doing. And we'll get to how many attempts of manipulation on the same area. But what I would suggest, if you do the manipulation and you're not sure if you've had the effect, so you don't hear the click, you don't feel the click, or the joint manipulation within your hands, retest the patient. Have they improved in quality and quantity of movement? Does the patient feel like something happened? Does the patient feel like that their pain levels have started to decrease? And if you're saying, well, actually, you're moving better, all right, your pain hasn't dropped too much, but you're moving better. We said movement is medicine. Get them doing some exercises. That way they will start to improve, and you don't keep smashing the person up. That's what you shouldn't be doing. So on that, how many attempts can you do to the particular area? To the particular area. How many can you do? How many manipulations, guys, would you attempt to the same area? Can anyone give me a number? Anyone? Have a go. There's infinite numbers in the world. You just need to say one of them. And I'll give you a clue. It's not 1,000. It's a little bit south of 1,000. Actually, we say 2. So what we mean by 2 is on the same area. Let's say you're aiming for C7T1. You choose the manipulation that you want to do. Now, bearing in mind for Jan, 1, very close, but that's your choice. And there's no right or wrong. Anything over 2 is wrong. But if you've attempted the first one, Jan, my man, 2, awesome. Or it could be Jan. Apologies. If you're starting to go over 2, then you need to stop. Why? Because basically, what structures take up or absorb the force of your manipulation? The soft tissues. And the more you do it, the more microtrauma you're creating, okay? And patients limping out of your treatment room, walking past your next patient who's waiting, limping, that is not it. You know, would you go into a electronic repair shop as somebody's walking out, laptop pieces, going, yeah, brilliant, that looks like a great place to go? No, your patients, they should be coming out, ideally walking on air. And the reason that they're doing that is because you haven't basically brutalized the area that you're working on. But again, that thought process, I take into every single technique that I do, whether it's dry needling, manipulation, mobilizations, soft tissue work, exercise therapy, anything. I don't want my patients limping out. All right. And we keep going back to the movement is medicine. What should we go to next? So I kind of want to go back to specificity. We briefly touched on it, briefly, but now I want to actually talk about it. How specific, guys, do you think you can be? So what I mean by that is C7T1, off the top of my head, if I had to, I could probably show you about 17 to 18 different ways to use manipulation at C7T1. But we're not talking about that. We're talking specificity. So when people say, I would like to manipulate C7T1, how accurate do you think they can be? Anyone? I'm just going to take a sip of my tea. So in terms of specificity, guys, how specific, Benz, what do you mean by loading? Give me some more information. But in terms of specificity, the question, what's the question again? The question was, how specific can you be with manipulation? So if I asked you to manipulate C7T1, can you do your techniques to only affect C7T1? The chat room's loading. Okay, the answer is kind of two-angled, the answer. If you're asking me, do I want to be specific, the answer is absolutely. And look, we've got a disagreement now. Some people saying no, some people saying yes. And this is the problem. So let's just kind of cut this away and say, would you like to be specific? The answer is absolutely. Absolutely. In reality, how specific am I? The answer is not that specific as I'd like to be. So what I mean by that is, I'll ask the question a different way. Is the body connected? The answer is yes, fundamentally. You know, from here to my foot, connected to a degree.